G'day. Welcome to the Sports Medicine Project. I really hope you're loading your tendons. I really hope you're loading your bones. I hope you're doing your isometrics. I hope you're doing your isotonics. And I hope you enjoy this episode. I need to say, skip to 18 minutes. Kelly and I just yarning for a bit for the first, but if you want to get straight into the juicy stuff with the first certified sports podiatrist in Australia, John Osbourne, jump to the 18-minute mark and you'll be right into the thick of it. Enjoy and have a cracking week, legends. G'day, welcome back to the Sports Medicine Project, episode 95 with John Osbourne. But before we get to this amazing, insightful episode, it's been a while since we've been on the airway. We've been away, we've been in Singapore, we've been at Vietnam, taking some holidays, which was good. Back to my normal scheduling now, so I thought I'd catch up with you, Kelly. How have you been?
I've been good. I know. I was thinking that too. I feel like it's been a bit of a hiatus from the old podcast mic, and I've missed it.
Yeah, only 1 week. I mean, we're still recording weekly on Patreon. We just recorded a research review, which we said from the start needs to be 20 minutes. If we're going through a paper, less than 20 minutes, people aren't going to be very engaged. For all our Patreon listeners aren't going to be very engaged, and we spoke for 44 minutes. So we've been keeping up on the Patreon, but for the main show, we're a week late. So it has been a while.
It's just so easy to tangent. Like you read something interesting and it's like, oh, but then what about this in a clinical setting? And then what about this? So then you just keep going and going and going. And then you and I can talk about that sort of stuff for a while. Particularly when it's on the Patreon and it's just let rip whatever you think.
Yeah, and I think why I think it's really valuable, and I can tell, I mean, if you speak to a clinician, you can tell that they're a clinician because you speak to them, and you would see it in our recent episode with Dr. Keith Barr, like you speak to someone about treating the donut, not just the hole, and
the way around.
Every single time, treating the hole. No, treating the donut, not the hole.
No, you just said
it again. Said it the same thing. Treating the hole, not the donut.
Yeah.
Because that seems like treating the hole within the donut.
Yeah, the hole within the donut.
Yeah, like as in like treating the whole donut. That's what
Well, that's it. Treat the whole donut.
I don't know how every single time that I say it, I don't even think I use that analogy anymore in the clinic because I just mess it up every time. But anyway, treating the hole. Treating the donut, not the hole.
No.
I'm just going to call it treating the degenerative part. That's how I'm going to talk about it now. So treating the degenerative part, always the follow-up question to that is, well, why does that matter? Like if someone has a degenerative part of their tendon, they can still get better and live a great life with, meaningful activity and no pain or minimal pain, regardless of if they have that degenerative part or not. But then if you talk to potentially someone that's more involved or heavily involved in the research, it potentially is a different answer. I don't know if you have found that a lot of the questions and the things that we talk about, we're trying to, because we're clinicians first, of course, it's like, that's really interesting and really cool and we love that. But then how does that really help us as clinicians and help the listeners that are clinicians as well? And I think that's really where the value comes. And that's what I've really been trying to think about because it's the important thing because the research is so cool, but it's that clinical translation which is the key for us.
Which is, I don't know if you've seen that graph that crosses over and it's like what makes a good clinician and it's sort of past experience, evidence-based practice, and then there's another one that layers over the top of it.
Patient expectations.
Maybe, yeah, patient expectations.
Yeah.
They're both important. Like you need both. You can't do one without the other, and vice versa.
Yeah. What do you think about this term, which I saw on the Knowledge Exchange? And I don't know who coined it. I'm sure it come from someone, but I just saw it there first. Evidence-informed rather than evidence-based. What do you think of that? So we are evidence-informed. I like that a bit. It made more sense as soon as I heard it. Because it's not, but the ideas potentially aren't based in the evidence, but I use the evidence to inform my decision.
Yeah.
Because sometimes you go against what the evidence would say and you potentially listen to more patient experiences and expectations and what's potentially worked in the past. I thought that was interesting.
I like that.
Yeah, that one was good.
I have heard that before too, and I think it is good.
saying evidence informed. But
I'm particularly excited to re-listen to this podcast with John Osbourne because I have been seeing quite a lot of plantar heel pain lately, and it's pretty tricky. And I want to go back and re-listen to this episode and just brush up again and make sure that I'm ticking as many boxes as I can with those patients, because I do feel like it is one of those stubborn conditions, and there's a lot of things that you can throw at it, but it's also just a really hard area to get on top of, I think, with the tools that I've got access to, because people are on their feet all the time, they're walking on it all the time, they're potentially aggravating it quite a lot, and Why
do you say that about heel pain when you're managing, conditions such as hip OA and knee OA? Would you see it? Well, I would imagine it would present very similar, where it typically has a longer prognosis, and people do typically have it for a long time before they present to the clinic. Is that how you see knee OA and hip OA and other conditions similar? Or say, now I'm going way above, I was going to say way above my pay grade, way above my knowledge grade, but like shoulder, rotator cuff related pain. What do they call it up on the shoulder now? I've seen that much stuff from Jared.
Subacromial shoulder pain at the moment is
subacromial. Yeah, so I would imagine it to be similar to that, where, it's probably the reality that they're going to have some pain for some time. It's very typical that the pain does improve, but function is the main focus, and living with pain is generally the focus, and coming to an understanding of that, and then whatever pain modulating tools.
Maybe that's it. Maybe it's the expectation that I have that needs to be worked on a little bit more.
Yeah, I'm certainly not saying I'm the expert in any case. I definitely see it the most out of any condition in the foot and the ankle. But I think the difference a little bit as well is you don't really have access to as many offloading tools, and I call them tools. I don't really mind the whole, not the tool in the tool belt, but I call them tools because I'm literally in like a workshop when I'm doing orthotic care and heel lifts and grinding and modifying and things like that. But you don't have really access to them other than heel lifts and shoes. Like you don't use intersoles. And tape
as well. Yep. Yeah. But then, you can't just keep taping patients every single week.
No, you can't. But I find like compression's a little good alternative to have between a session of taping. Like I recommend to patients generally 2 days of tape, 2 days of compression sock, 2 days of tape, and they can continue that.
I actually ordered those compression socks into the clinic recently. So I've got those now.
They're great.
So that will be good.
Yeah, they're easy, they're washable, they're really effective for patients.
Do you give them to just the one foot if it's only unilateral symptoms? Do you just give them to the one side?
Yeah.
Okay.
What would be the reasoning for two?
Just like, I would feel uneven, I think.
Yeah.
Me personally, I just.
Yeah, well, hey, patient expectations. You got to listen to that.
Different sized shoes.
Yeah, I that could be the case. I haven't yet, and I'm not to say it won't ever happen. I haven't had anyone tell me that they were uneven and they walked out the door, right? They're pretty happy to just have something tight.
Just me.
But how do you find? I mean, even when you were learned in your undergraduate as a physio, you obviously learned about orthoses foot orthoses and foot orthotics. Like, did you ever think that you would be prescribing or utilising them? I know plenty of physios that use them. Podiatry doesn't have a trademark on them. We just think of them as load modifying tools, potentially force, shock attenuating tools, those kind of things. Like, did you ever think you'd be using them more, or do you think that you should use them more?
I would rather the patient see someone that's better at it than me.
Yeah.
If I'm being honest.
Yeah. It always...
like if I was living rurally, then I would more than happily upskill and learn how to make them or use them. But I'm lucky in having access to you guys and being able to send people to you to do a better job.
Yeah, send them to podiatry and that kind of thing. I guess the nuances of, using custom orthotics versus off the shelf and being able to modifying. And there is certainly an art and a science to it, but I do wonder how many people would benefit from just a simple soft inner sole without any modifications. And this isn't to take away from podiatry in any sense, but like you said, if someone was rural, didn't have access to podiatry, I mean, it wouldn't be too much to upskill and learn how to do some really basic modifications. And I think most of the time it probably would help.
I remember learning in uni that you'd stand on it and you'd put the hairdryer on it and smush it into
Was that a pink one? Was that a form orthotic?
I remember.
Yeah, most of them are like that.
The podiatrist that was doing our tutorial told me that
tell this story.
He said I was going to get a big toe away one day.
I can't believe that. Yeah.
What do you say? Because of my calluses?
Yeah, I think you had a bit of callus, and you've got a more of a cavus foot. But imagine just it boggles my mind to think that you can look at someone and just say, you are probably going to get big toe away, and just have it as a throwaway.
No, he was like, you need to put these orthotics on, or you're going to end up with OA
that really,
in your big toe.
Yeah.
Even this. So even though I'm like, I don't care about you, you're just talking trash. But I can still remember this.
Yeah, at the time you wouldn't have thought that.
Well, I don't think it fazed me too
bother you
much.
at all?
But I remember it. Like, it must have bothered me enough that I recall that.
Yeah.
I don't remember much else that was said during that lecture, but I do remember that he said I was going to get away in my big toe.
I wonder why sometimes a profession can, and that, like, I would think that is probably the gripe that our profession gives other professions the most, is, you know, whether it be orthotics that are uncomfortable or prescribing when they're not necessary or whatever, but it probably is orthotics. But you hear cases like that, and I'm sure all health professions have similar examples, but to tell somebody that is just ridiculous. Like, even if you just, one follow-up question would be like, how do you know that? And I could not even imagine the answer.
It's because of my callus.
Yeah. But just, does that mean that in all my hands I'm going to get big toe, like finger away? That's why. And
any wear pattern is
an
indication that joint is going down.
Anywhere you put force, that joint's gone. It's inevitable. But so imagine if you were, and I think of the case of a child coming into a clinic and a mum and a dad, and you're in the consult with someone, and they're like, yep, this anatomical variable is going to result in this. I mean, you imagine hearing that as a parent, how worried you would be, and how concerned you would be. And then, depending on what kind of person you were, you could just prey on that so easily and just say, yeah, this is potentially going to happen. I got things that can help, and it's in the form of this very expensive treatment or these very expensive follow-up treatments you need to come and see me for. Yeah. Actually, a couple of people messaged through. I posted about a study yesterday about an RCT of acupuncture for Achilles tendinopathy. So they compared heavy eccentrics versus acupuncture, and they looked at the vis-a-ray, the VAS, pain at rest, and then I think morning stiffness, and acupuncture on all those variables over, it was either 8 weeks or 12 weeks. No, it was 8 weeks. Acupuncture over that period of time showed to be, again, not statistically significant, but it showed to be superior to exercise.
In helping?
Yeah. Have I not spoken to you about this study?
No.
So this is the one that I didn't talk about it in the Patreon video that we did of the whole review, just because I spoke about it on the Instagram. But have a guess of the protocol for how many, because you read that and you go, what? Acupuncture was superior to exercise? How many times do you think that they...
Every day?
No, not every day. How many times a week? Start with that.
3.
3 times a week for 8 weeks. So 24 sessions they had at 30 minutes, which is crazy. So I posted and was like, it's a lot. I don't know anything about acupuncture protocols. Someone messaged through, and I'm not going to name who it was, but they said that their wife was pregnant and they'd been recommended to have some acupuncture. This person said that was a similar protocol that they followed. However, they went in, and he must be a health professional. I didn't actually check out his profile, but they were saying that he went in there and there were 6 people going all at once, and the acupuncturist was going around and seeing them all.
Wow.
And that's a very similar protocol. Could you imagine seeing someone, and they were booked out for like 4 or 5 weeks? I don't know. I mean, if it helps, I'm not going to say anything to anyone, but that seems very...
Gosh, wouldn't it just be so much easier to be a clinician like that, though?
Just
like, why do we have to be so morally correct?
What do you call it? The ethical... Ethical considerations.
Cleansing.
Yeah. Ethical cleansing, I think is what you mean. But that's exactly... So obviously the benefits of seeing someone for 30 minutes... 3 times a week for 8 weeks is going to have some psychological benefit of just talking to someone, seeing someone, potentially having hands-on therapy, potentially just having all types of conversations. But I found that really interesting.
What was the exercise group? Did they have supervision,
Yeah,
or were they
so
going into a clinic 3 times a week?
It was a bit vague. I can only find one paragraph on the exercise part, and I'm going to try not to butcher it, but they were doing heel raises to a little bit of discomfort, and told when it felt okay, they could add a 5 kilo rucksack. Didn't talk about compliance. Talked about just different heel raises off a step. Didn't follow any particular protocol. Yeah, didn't say if it was at home. And they just said progress it. Didn't talk about compliance or record that. So yeah, it was just a little bit hard to understand what exactly they did.
That's a bit of a limitation in the study to not outline that. Like if that's their comparative group, then you should be...
I don't know if it was in an additional file, but I couldn't find it through the study. I only probably went through it for 30 minutes, which, don't get me wrong. I'm sure you need more time to go through a study. But, I couldn't see anything more. But I thought that was pretty interesting. Because then when you look at and why I was going into this is when you then look at the review, which we did for the Patreon, we talked about, there was a study looking at adjunct therapies with, tendon treatment with or without adjuncts. That's what it was? Yeah. And I was looking at how acupuncture was ranked very highly as a really effective treatment, but then they based it off that one study. Or that was the one study that I could find. And then you look at the study and it's like, wow, if you just look at this other review, which includes all these reviews, you're like, wow, acupuncture is really well and fares really well. But then if you look at the other part, if you look at the study, it's not that good. But then if you look back at the review and where it ranks exercise, it ranks it pretty well, but not superior in some cases to acupuncture. But then if you look at all the reviews that are included on exercise, there's lots. So obviously that is more rigorous because there's lots of studies compared to only one study. And there are studies that are better well done.
Yeah, that's interesting.
Yeah, so we'll leave it there. Enjoy this episode with John Osbourne, sports podiatrist, and we'll speak to you guys in a couple of weeks. Before we get into this episode about Plantar Heel Pain with John Osbourne, have to introduce this lovely and intelligent man. He was and is, the first podiatrist to complete the certified sports podiatrist pathway in Australia. He's currently studying his PhD looking at the relationship between foot strength and lower limb pathology. He's practicing at East Brighton and also in Highton at Pursue Health. I am absolutely certain that I pronounced that wrong. So in this episode, we talk about plantar heel pain, strengthening for heel pain, pain management, what potentially is going to help people, what's not so helpful, and just everything to do with plantar heel pain. I mean, we know it's one of the most common conditions that is going to present in the foot and the ankle. Some research quotes 9%. Some research quotes up to 14%, so it's incredibly common. And it's a condition where lots of research has been published, but we know it's not a this for that, or when someone's got this, you do that. It's a condition that involves a long prognosis and a condition that can really affect someone's quality of life. So if you're looking to find John Osbourne, he is on Instagram, The Agile Foot. He's also got his own his own podcast, so go and check that one out, Simply the Best Podiatry, and we'll tag all his social media, his website below, and where you can find him. Enjoy this episode, guys, and we'll speak to you next week, and I cannot wait.
Correct. It's the funny thing is if we talk about the is there an answer? I mean, as you said, there's not. But I think the funniest thing is the Delphi paper, which is what I'm assuming you guys have read.
Yeah.
There's a paper that I've got the data sitting here for, which I did a presentation at SMA on, which in many ways is probably more interesting, but it certainly comes out and perhaps refutes, or it's a lot of things we said the experts said is a bit like, well, actually they're probably not on the right track at all.
Right.
So
that'll be good.
It'll be a bit of a watch this space. So here comes out comes the Delphi, and then 6 months later, well, I probably actually wouldn't do what's in the Delphi, but I would do here because the data supports that better. So
yeah.
Why do you say that? What do you, or should we?
Yeah, maybe we'll talk about it in the podcast. There's the whole idea of the talk, isn't it?
Well, you asked the question. You're recording anyway. Just slice it how you like. But I think it's just more that we start to learn more about what these exercises do. I think if we look back on the history of how we do a lot of these exercises, and I've got to be careful about how I perhaps explain some of this stuff if it's going to go live, but because we want to assimilate some of that data more. But really, we've sort of done a lot of these exercises, and I use the toe yoga and short foot as the example. They're really easy to put on Instagram, and they're really easy to sort of catastrophize and sell, like your foot posture is this and you can't wriggle your big toe. But if we look at walking, how often is our foot really a hand? Like, we're not picking up, like, there are a subsection of the population that are going to need to use their foot as a hand, but you're pushing off with your whole foot. You're pushing 70 kilos, 75 kilos, 50 kilos if you're small, of body weight with your whole foot. So doing all these fiddly little toe exercises, etc., are probably not proportionate to what we expect of them, particularly in the circumstance of plantar heel pain. So hopefully the EMG and force plate data, which comes out later in the year, can then turn around and say, well, okay, we know what muscles are active. And if you look at those papers, it's all about, well, this muscle is really, really active. But it'll be able to say, well, if we're going to flex the toes, we're going to flex it over a series of 16 exercises. These are the muscles that are active. But the factor we're not talking about is how much load and force are they producing, which is really, if we're talking about strength and gains and those sorts of things, do you even lift? Then that's probably more important. And that's hopefully what the EMG study comes out and shows as a result of all the exercises that have been sort of come up with in the Delphi.
Yep. All right. Well, I'll just turn this.
Does that answer your question?
Yeah. I'm excited to go into more depth about the foot intrinsics and toe yoga and all of those sorts of things, and sort of where we think that came from and where we think it's going to go, because it does seem to kind of go around in circles. I find like it's that someone will say, oh, it's not effective because no one will actually do it, and then it sort of comes swinging back and everyone's like, no, you've got to do your foot intrinsics, it's so important, and then it kind of drifts off again, and it just is like, well, I guess with a lot of things as well. But and then also, like, we know that we know exercise is effective, but we don't really know by which mechanism. So then do we need to be so specific with things like that, and why does that keep circling back? So that would be my thoughts on all of that.
Yep. Yeah, I agree. I think it would be really fun. I think it would be a really fun study to do. And this is probably a postdoc, but I think that exercise, from what I've been, if you look at, there's a whole bunch of stuff on strength training came out of Journal of Strength and Conditioning Research, which is Mark Peterson and his bunch. And they've actually done a dosage, like they tell you what the dose response relationship is for strength. And when you look at the papers that the dose, and even if you look at a lot of professionals, we turn around and go, oh, I'll do 3 sets of 10. And then we sort of try and find a weight that kind of works. Now, we don't have to push everyone to failure, but we do need to push them. So they need to be, working at a good percentage of their 1 rep max. I think it's somewhere around about at least 65% for a trained individual. But then if you get an athlete, you need to be pushing them above that 85% of a 1 rep max for them to gain a strength gain. Okay, so we're not necessarily talking about, if we're going for muscular endurance, then you are going for repetition volume, but you're still wanting to fall within that 5 reps to go, right, failure rate. So pulling up a bit short of an absolute failure, but you're still trying to push yourself. And that's probably and that's, I think, the hard thing when it comes to trying to then prescribe exercises and exercise programs for people. And then, if you drill that down further into doing toe yoga and stuff, I'll just bring it back to this: there's no load. We're trying to get toe yoga probably has value in someone who's in a moon boot, is not able to move yet, but there's just no load in it. So it's good because it's not aggravating, because it's low load, still keeping muscles active, so they're on and they're working, and we might, you won't lose a whole heap of. You'll still lose atrophy, or still get muscle atrophy as a result, but they'll at least be active muscles moving if you're doing all that sort of thing. But you're not putting any load through it, so you could argue, but it's still while you're in a moon boot. But if you're an athlete trying to jump and run, me getting you to wiggle your big toe, I'm skeptical on how effective that's going to be for the vast majority of people. There's always going to be outliers. So for the people that don't go for the usual stuff, fine. There's going to be some value in it, but we're talking, data can't give us the average values. It's not going to, and then there's always outliers.
Do you think it's like, you see in the other research that, any kind of movement seems to help people, but there obviously seems to be as you said, a dose response or a ceiling with a floor where if you do lots and lots and lots, you probably get diminishing returns, and it potentially isn't that much more effective if you do 100 reps versus 200 reps. But if you do 2 reps, it's probably not as effective as if you do 100. Do you think that the toe yoga and the foot intrinsic stuff is still effective from that point of view? And I guess the two different domains would be, not to say that we're treating pain, but if we're trying to help someone with pain with movement versus function-wise, when we're trying to get someone back to running 5 or 10 kilometers, do you think it holds any value? And with the research say it holds any value that if someone has plantar heel pain, an option you can give them purely for pain modulation, just like rolling a ball, is doing some foot intrinsic stuff like wiggling your toe. But when it comes to someone that wants to get back to their meaningful activity, then it needs to be more tailored, like, hey, if you want to run 5K, you should be able to jump and calf raise and these kind of things.
Yeah, spot on. So if you've got a CRPS patient, then trying to load them up in a calf raise is way beyond what they're, So some toe yoga might be a really appropriate thing. I think I've got a patient who has a lot of chronic pain, has Ehlers-Danlos and POTS and mast cell diseases and all sorts of things. So it's a complex patient. And we might use toe yoga when she's having, a really bad day, just so she's still feeling like she's active. And then on a really great day, she might do a couple of calf raises. It's absolutely, I mean, that in that sense, I think it's all relative. And going back to this, I think it'd be a really interesting experiment to run. I probably shouldn't say this out loud because someone will do it now, but maybe they should. Maybe it'd be really good. It would be, I think it'd be really fascinating to go, okay, well, here's a population and we're going to give them a standard treatment. So let's say it's a heel pain population. We're going to give them a treatment of foot orthoses. We're going to give them a really well thought out, well planned out strengthening program that meets all the reporting and it meets, all the requirements. And then we're just going to say, jump on a bike and lose, and go see a dietitian. And I kind of reckon that if you had the average 50-year-old overweight person and they did the last one, they'd probably get the same outcomes or maybe even better because we're just getting them moving. But the one thing we never talk about with exercise, because we all go on about how great it is how difficult it actually is for people to do and the fact that they're just not going to do it. I mean, that's why they're in your room in the first place. Yeah. So I think that's the big limitation we don't talk about.
I guess there's also like two sort of subcategories of people that end up with plantar heel pain. There's the more athletic type, and then there's the more sort of middle-aged, overweight, or lots of lifestyle factors contributing to potentially that presentation. And I wonder if you could classify the demographic or people, then would that be different as well?
Yeah, I think so. There's a paper out by Henrik Reel, I think, and some others, where they talk about that we really need to subgroup some of these pathologies. So I know they're doing the same in Achilles tendon. They're trying to subgroup and subtype who some of these populations are. I know clinically, I certainly see that there's some subtypes. I think there's probably some work coming out regarding the relationship to psoriatic arthritis or arthropathies and heel pain, because again, they are all different populations. So if I've got a psoriatic heel pain patient, maybe steroids and those sorts of things are really helpful in that circumstance because you're trying to manage something completely different, or you're trying to manage them almost systemically as opposed to the person who is overweight and has had heel pain for 12 months and put on an extra 15 kilos over COVID, and everybody did it. So not pointing any fingers, but like they clinically, they appear to be really different populations. You just don't have the research data to yet back that up. But given that Henrik's group or Michael Rathoff's group really, came out and have already published something to sort of say, well, really, we need to look at that. I'd like to think that maybe someone has started to, and if not, there's a postdoc.
Is there differences in the pathology across different population groups, do you think?
Yeah, I wanted to ask around the tensile, to some degree, the tensile versus more compressive, when people have really the majority of their pain when they strike with their heel or putting pressure through their heel versus some people that have it more I guess, at the base of the arch more and through the arch, but they describe it very similar. Worse in the morning, warms up, worse at night, worse if I've been on my feet a little bit longer. Do you see potentially rehab being a little bit different for them? Because one, in my mind, the more compressive one just sounds really just like a heel bruise, and we just need to remove the provocative loads and then gradually reintroduce those over time, versus the more tensile, which everybody says treat it like a tendon and it should respond like a tendon. But if we look at the tendon research, they're completely different to tendons. Like, they're not like a tendon in any way at all on their physiology level.
Yeah, I think that's the bit that I always get stuck with is I go, but it's not a tendon. It doesn't contract. I appreciate that if we look at developmentally that the Achilles and the plantar fascia have some relationship there. I don't know. I almost wonder whether it's, if we're talking about it from a pathophys perspective only, and this is just my musings, I have nothing to back this idea up. But if we think about your ITB, so if we turned around and we said, well, the ITB is just an extension of the glute med, would we all go, oh yeah, absolutely, we should just strengthen glute med because that'll fix ITB? Or are we going to laugh ourselves silly because that was a really dumb idea? So, and yeah, that's probably inflammatory language, but like, I do wonder whether actually the plantar fascia is more like an ITB than it is really just an extension of a tendon. So, and if that's the case, maybe we're thinking about it in the wrong way. If we go back to my paper in 2019, which was a review looking at whether there's strength differences in people with heel pain compared to people without. So it's just taking a snapshot of time and saying, well, if at this point in time we measure people who do and who don't, who has bigger muscles, who doesn't, there's no difference in calf rise capacity between the two. Now, if you're looking at a tendon, I think there's a reduction in capacity if you've got the tendinopathy. So if it's tendon-y related, why would there be a reduction in calf rise capacity? And if it's an extension of that Achilles? Now, I'm making a lot of assumptions and I'm drawing, a long bow from that. But it sort of further asks my question, like, why would we do that? Like, what's the relationship there? So, and even then, a new paper just came out earlier this year saying there doesn't look to be much difference in foot muscle size compared to those without. And it does. It sits right on that borderline. But so does a lot of the associative factors, or so does a lot of the issues and treatments that work for those with heel pain compared to those without.
Do you think that we're getting a better understanding of it? I mean, I tell people all the time, it's easily the most common thing that I see. And I think the literature between 9 to 14%, I think the average is like 11.5% is reported. But this whole idea, and I wanted you to speak to it, definitely between the tight calves and the weak calves, and people coming with heel pain, if they've had pain for a long time, someone will test a couple of things, whether it be their foot posture, their ankle joint range of motion. Do you think, and purely, based on the research and your experience, do you think any of those are potential risk factors for developing plantar heel pain?
So if we can look at it from a research perspective first, we can look at the associative factors. And the associative factors sort of weakly say that having reduced dorsiflexion range is associated. So those with heel pain are generally more restricted. We don't perhaps necessarily, I don't know, I haven't dug enough into that specific literature, but I wonder, is that kinesiophobic? So is that, have you got less range because you're kinesiophobic? We know that those who have got heel pain are more kinesiophobic. But so that's there. We've got, there's the different foot shapes and foot types are associated. You've got footwear and hard surfaces is associated. But the biggest one, far and away, the biggest one is BMI. So if we're ever going to sit down and turn around and say, well, what's associated with BMI? So I suppose when then it comes down to, for me, clinically, and my personal interpretation of all this is it's a bit of the biopsychosocial approach, I suppose. I go, well, what's this person into? Because if all the different treatments are, hazy at best as far as their effectiveness, which one works better for which person? So I start with the basic stuff and just work with the patient to see where they end up. And if I had someone come in, they went and had a cortisone like 3 days before I come in, I'm feeling great, but I still want some exercises for my heel pain. I'm like, but you don't have any heel pain. Yeah, but I just want to stop it from coming back again. Like, oh, that's fair. Okay. So look, gave them some exercises, but who's to say that cortisone doesn't do its job? Regardless of how, the thought process behind that, that's when they've turned up to see me. But there's the paper by there's a review just recently done. I think of it as Matt Kocher, but he wasn't the only author. There's quite a few.
Yeah, he's done a lot of heel pain research.
He has, yeah. He's not the primary author on that though. Where they did a review and they asked clinicians, they asked patients about what would be the best, course for management, and they've mapped that out in that paper, which is quite nice. So then I think they talk about the early stage stuff is using foot orthoses because they take the pressure off, using that specific plantar fascial stretch, and then moving into shockwave, and then moving into cortisone, which seems to sort of map out how I would generally treat anyway. But as far as foot strength in that treatment paradigm, it's not in there because there wasn't enough info to include it in there. But I wonder whether that becomes population and person specific. So if it's the 20-year-old runner, I'm probably more likely to try and use that approach than if it's the overweight 50-year-old man.
What do you think of the, I'm going to butcher his name, the Ralph protocol with the, it is Ralph, isn't it? Toe up, like the big toe extension. Yeah. And then, we've seen that time and time again brought up, and then, things are developed as a result of that. Do you think that is the best way? Like if someone listening to this is thinking, I want to target the plantar fascia as much as I can with some rehab, and they're not too irritable and they're really engaged, in what way can we target that other than, the big toe up in the air? Or is that the best way to do it?
Right now, that's one of the, it's the one that's used the most frequently. It probably gets the most social media attention of any of the exercises. If you've got big toe OA, good luck to you though. I can't tell you how many times I've got big toe OA in both I just can't demonstrate it because it's way too aggravating. If you asked that group, would they do it? I think they would say no.
As in to do that exercise?
Yeah, I think they would say no. So I think in the right circumstance, maybe. But I think that, it's quite simply just get someone to lean forwards. So if you just lean forwards, that will load everything more than lifting your big toe off the ground. So I like the premise of the idea, and it was an inspiration for me to take on some research in its own right. So it was an article I think that inspired some fire in a lot of bellies, but I don't do it. I haven't done it for a long time.
Yeah, it kind of gets seen as it's almost like, if this has failed, now try this. Like try this one with the big toe. Like it's just really super effective. This is kind of next level stuff. But again, then like you said, it's not that much more of a difference from doing a normal calf raise or just leaning forward. And there's probably other things you can do, hopping and jumping and off a step or weighted to load it up a little bit more. Yeah,
just load up by doing a calf raise. It's like if you just look at it from a physics perspective. So the objective is it depends on where you read it, but people will talk about it as if you're strengthening the plantar fascia. It's not a contractile tissue, so you can't strengthen it. So you're strengthening the tissues around it. So then if you're trying to strengthen the tissues that are the flexors of the digits, we're winding them up to maximum extension. So maybe because you've got them on maximum extension, they might have to do something, but they're also not budging and not moving anyway. So we've wound them right up. But as a result too, we're shifting our center of mass behind us. So we're actually reducing the lever arm about the MTPJs because we've shifted everything behind us and we've put them into extension. And so I think that we're actually underloading then the digits that are going to create flexion about that joint. So if they are the muscles we're trying to target, if we just simply have ourselves flat and we just lean forwards, we will create more torque about that joint and therefore more stress on those muscles and so on and so forth. But in many ways, I'm speaking early, but the results of what that looks like, I can show in a paper in hopefully under 6 months.
Yep.
Do you think plantar fasciitis or plantar heel pain is sort of similar in that to a tendon, say, in that it's due to the person maybe not coping that well with loading, and that's why the plantar fascia is getting progressively more irritated? Or what is the sort of narrative or your sort of understanding about why they're getting it, and then how are you conveying that to the patient?
Tall flat feet, tall foot posture, tall collapsed arches, fallen arches, wrecked
All
arches.
flat feet, yeah. Yeah, it's it has to be load related, doesn't it? Like if it's you don't see it in the 50 kilo chest player, so it has to be load related, and I think that it thickens in response to that load. So then the theory becomes around strengthening. You go, okay, well, if we make the muscles that run parallel to it, if we make them stronger, do they then carry more load that the plantar fascia doesn't? I think there's been a lot of stuff that's come out that perhaps really makes you have to rethink it. So there was the paper that came out by Anya Verena Belling, where she looks back at all the theories of foot function and sort of shows that really the windlass mechanism doesn't stand up. So the foot is designed to absorb and dampen and flatten to absorb loads, and then it is designed to then use the muscles to generate some power to propel us forwards. Previously, we would have thought that the plantar fascia is doing that because of the windlass mechanism, which then goes back to a whole lot of the other conversations we've already had around its contractility, etc. But if the muscles are the ones generating the power, you would think, if it's load related, that if we get the ones that are flexing the digits, which is running parallel to the plantar fascia, maybe we're going to get more out of that. So until proven otherwise, it's not a bad theory. But again, I do wonder whether you just got to pick the population for it. If you've got 140 kilo, 55-year-old, maybe a dietitian and a bike is a better place to start.
Yeah.
Than trying to get you to do, a foot exercise, which if you haven't done any exercise to begin with, me trying to give you something really specific, how helpful is that to that person?
Do you think that that's where that sort of tendon model has come from, where people sort of start to treat the plantar fascia like a tendon? And then what are the flaws in that? Like, what do you think in your mind? Are you sort of looking at that saying, oh, that doesn't really hold true, because as you said, the plantar fascia isn't attached to a muscle, so it doesn't contract.
Yeah. So, I mean, look, it's it not attaching to a muscle. I think there's plenty of arguments to and fro on that. I personally see it as more like an ITB than as an extension of an Achilles. I think it's pathophysiologically it's different. I mean, even if we think about, I think it's just a really sensitive structure as well. So I do think that we do target in that way because it's a really clear and makes a lot of sense to us, right? If we turn around and we go, oh, okay, the plantar fascia is sore, that's what I'm going to target. If you go and you look at the literature before we had plantar fasciopathy, where it was bone spurs, okay, well, if it's a bone spur, that's what I'm going to target. I'm going to slice that off. So again, it probably comes back to our definition of it is probably still lacking, which helps no one listening to this because they all go, well, that's great. No one actually knows what it is I'm dealing with. But I think that it's a really sensitive, the fascia is a really sensitive structure. So there's a whole bunch of Italians that are coming out and talking about the sensitivity of fascia. And I know sticking EMG needles into people, if I touch any of their fascial bands, that person's out, they're out of the door. Whereas they're not coming back.
They're running down the line with the needles hanging out their foot.
There's an electrode still stuck to you. But if you can avoid that, they're less sensitive. So, having done that, I went, gee, I wonder if there's, if you get a needle and you poke someone's plantar fascia and it's really thickened and really hypersensitive, are they more sensitive to it? Don't know. But I think it is a really sensitive spot. It does show up as thicker being on ultrasound. So there's obviously, it's doing something.
Yeah.
I'd like to know more about what it's doing though. I'm probably not the person to answer that.
So what's the two questions with like the research around it? What's the limiting factor when we're trying to work out what is happening during a normal gait cycle with walking? Is it because, we can't, stick needles in people's bones and stick needles in people's muscles and then watch them walk with lots and lots of people? Like, is that what the limiting factor is? I heard that people were doing that they were doing it with some cadaver studies, like making people, making the foot move and just seeing what's happening, like to really understand what's going on biomechanically.
I think we're learning more and more and more about how the foot moves. I think we're sort of the more we learn, the more we learn. So again, I'm probably the wrong person. Certainly the bunch out of UQ have done heaps, and Griffith now have done a lot in terms of looking at foot function and how it moves and how it works. The foot, I think what they've really, as a really, really broad summary, the foot's just a really mobile structure, and it's supposed to be a really mobile structure. So talking about it as being a rigid structure is probably not quite right anymore. And we use the muscles to create force, and we use the joints, the bones and the joints to move around them. And that seems to make sense because that's true of the rest of the body as well.
Yeah.
So for me, that's how I visualize it now. Then you go, okay, well, what about gait? And gait assessment and those sorts of things. I don't use gait assessment much anymore in clinic, if I'm honest. It's something that I just don't use that frequently because my eye's not going to pick up 4 degrees of motion in a joint. And even my fingers trying to draw it.
You'll get there. I can pick up like line.
Thanks. I just need more practice. I need more practice.
Yeah, you need to do my
skills.
course, my gait course.
I apply the principles and use the principles rather than necessarily go, oh yeah, okay. So, because, if you've got the principle of a tib post and a pes planus foot tap, I say, okay, well, you know what? If I theoretically take pressure off that tendon, how am I going to do it? Well, I'm going to do it in this way. Does it work? Yeah, great. And then it might be a little bit different for you and for me and for everybody else, but that would make sense because we've got so many joints and things to play with.
Can you speak much to the EMG studies looking at muscles and where that can be problematic, and any of it is problematic, where you look at a muscle and see what it says on the EMG and if it's really active, what does that mean and what kind of pitfalls that can have?
So EMG gets really heavily criticized. So there's 2 ways of doing EMG. One is to stick a needle inside someone's muscle, and the other one is to use a surface. So depending on where that muscle lies is where it sits. Now, if you let's say we're sticking a needle inside someone, it's got a range around that needle of which it will pick up the muscle units that are active. Okay. So you won't get, if you stick a needle into your medial gastroc, you're not going to get the entirety of your medial gastroc. You're just going to get the section around that needle. So that's one of the criticisms, because you're not getting the entirety of it. You're getting just a subsection of it. And if you have too many sort of things too close to each other, you'll get crosstalk. And so there's a lot of chance for things to go wrong. But it does provide some quantitative measure. How good is this new update from Apple? Let's get the fireworks going.
Oh, look at that one. So, listeners, you can't see this, but there's fireworks going behind. John is speaking that much knowledge at the moment.
So it needs to drop bombs. There needs to be a way to get to drop bomb. What it does give a way of quantifying it, right? So if you go, okay, well, I've got a gastroc needle in and I've got a lateral gastroc needle in, which one's firing more? I can still make some inferences that, well, that one's firing more than that one. So you can see that which one's more active during a particular activity or a task. And that's all it's showing you. So it's showing you how active is that muscle at that point in time. We've often assumed that more active means more load. And they're not the same thing. More active is just more active. So I could have a huge amount of load going through a muscle, but it's not very active. And if all that load's going through it, but it's not very active, and another muscle is more active, it's more likely that muscle that's more active is going to be taking on that load. Similarly, I could have a really active muscle and there is 0 load going through it. So it's not really going to adapt a lot, but gee, it's turned on. So I think that I've learned this, and huge props to Luke Kelly and those guys for what I've learned from them. But it would be, once we know which muscles are active, it then becomes about load magnitude. So I think it's better to understanding both than just understanding one. So you can absolutely say that if I do toe yoga, then the abductor hallucis is working harder than flexor digitorum brevis. Great. So now I know that when I do that exercise, I'm more likely going to be targeting that muscle than I'm going to be targeting the one that's less active. But I can't tell you how much load's going through it.
Okay, and that's kind of what I wanted to hear, because you see that as well. Like, hey, there's this study, you see this big upshoot of activity, and that means that this muscle is really active. We have to put heaps of load, and that's when we have to get strong. But as you're saying, it's not the case, especially if you're saying that a muscle can have lots of load to it and not be very active.
Well, it can, right? If let's say, for example, we do a squat. Okay, do you even do leg day? But we can do a squat, right? Let's say you're a king and you put 200 kilos on your squat and you do the squat itself. I've probably got a little bit of activity going on in my abs. I've probably got a bit of activity going on TDAN, probably a little bit of activity going on in my foot muscles, probably a bit even going on in my shoulders to try and stabilize that weight. But the vast majority of activity is coming out of my thighs and my glutes and my hamstrings. Then they're the ones that are going to be carrying the vast majority of the weight that I'm pushing. So similarly for a sled, right? If I'm going to push a sled, the muscles that are more active are going to be carrying more of that weight. So I'm still carrying a huge amount of load, but if I'm only got a small amount of activity in it, I'm not getting much gain out of that into that muscle. I'm still getting a small amount of gain in it, but I'm not getting all of the gain. Does that make sense?
Yeah. Yeah. So what do we see in the foot muscular throughout the kind of walking cycle as carrying the most load?
That's a good question. I don't know. I didn't prep that one. It does depend. It depends on what point in the gait cycle that you're carrying all these things, right? So, you're better off going and looking at the stuff by Luke Kelly. He's got all that stuff already out there in papers, and it's pretty easy to understand. But, the plantar flexors are the ones that are really driving the force within the gait cycle. So, I was trying to find some comparators of walking muscle and load activity, and the best paper I came up with was actually a comparison of monkeys to humans with some modeling and showing how much happens within the humans as part of gait modeling and loads and muscle activity at the same time. It was quite a cute little paper to read, but when I find it, I'll flick it back to you so you've got a copy of it. But it's the plantar flexors that are driving they're moving the way we expect them to move, put it that way. And then when we're pushing off, we're not just using our hallux to push off. We're using the entirety of our foot muscles and the entirety of our calf to push off. So we're using all of these muscles together. There might be small differences in activity, but they're only small differences. They're not big differences. It's not like my shoulders stabilizing a bar versus my quads pushing off. They're all working, and they're all working 60 to 100%, which is enough to have them active. So they're all going to work together, and they're all going to help each other out to produce that amount of force. If you want to try and move 75 kilos, you can't do it with one muscle, in the foot and ankle, because they are also small. But part of the benefit of them being the size that they are and working within the range that they work in is they're really hard to fatigue.
And so, as you said, there doesn't seem to be a difference in calf capacity or calf strength in someone with plantar heel pain, but maybe there is a lack of dorsiflexion. What other things are you seeing clinically that would be some sort of like key assessment findings for someone with plantar heel pain? And then what's that sort of telling us?
Yeah, okay. What do I try and just rule out the differentials. So if I'm doing an assessment, I'm trying to rule out, do I think there's a bone stress? Do I think that there's some nervy relationship to it? Is it pain? Is it a kinesiophobic more than it is pathologic? Is it the plantar fascia itself? Is there perhaps a contusion of the fat pad? Like, just try and rule out all the weird and wonderful. And they're weird and wonderful for a reason. So they're rare. So you expect them to be rare. You don't expect to see 5 in a day. I think if you're seeing 5 in a day, maybe I'd probably go back and go, maybe I need to rethink how I'm doing this. But, you know, that's what I'm probably doing as far as my assessment. I'm going, okay, well, what are the other structures based on what's presenting here that I'm just making sure that it's not that? And if at any point I'm feeling a little bit suspect, you know, getting some imaging out or doing something just to have a bit of a closer look. But that's what I'd be doing in my assessment more than the other stuff is, okay, well, if I think it's heel pain, I've sort of got 5 or 6 things. Let's start with some simple stuff that is generally more effective, you know, stretching and orthoses, etc. And then work my way through it and go, okay, well, is this working for you? Because, you know, you'll see the hypermobile person who's got plantar heel pain. You can't give them a calf stretch. So we could, but they've already got bucket loads of range. So they're probably not going to use that 60 degrees of ankle range. So they might benefit from some calf strengthening stuff.
Are you speaking to people about pain itself and trying to address, you know, catastrophizing, kinesiophobia? We know those things are associated with plantar heel pain, as well as doing your, and again, it's not the greatest description, but like your mechanical treatments like foot orthoses and stretching, which I guess aren't really ever mechanical because there's other things that go with that. But are you kind of speaking to people about those things? Because as you said before, if BMI is a really, you know, high risk factor for people, that's very hard to talk to people about, and it's very hard to address in the short to medium term, you know, for anyone with these kind of things. But are you speaking to them much about that?
Yeah, absolutely. I think it's a huge one. The more I've practiced, the more I've sort of tried to treat the person and less the pathology. But I think you've got to treat them both. You can't just go, oh, you know, it's okay, Kel, you know, you'll be all right. Like, because it's only going to go so far. So, but I think if you can do it with a sense of hope, and you give them a sense of hope, and you give them some planning, and you give them some, okay, if it doesn't go well, it's okay. We'll tweak and we'll adjust and we'll modify based on how you're responding to these things. Then I think if they've got a little bit of hope and you're making progress, if you're not making progress, you have to go back and rethink what you're doing and how you're doing it. And that's why it's a shared responsibility. So the person comes in and they go, well, that's great. You stuck a thing inside my shoe. You've belted me with a shockwave machine and I've been doing these stretches and nothing's changed. Okay, cool. So these are the ones that I know of that are available left. What works for you? I really think that's going to work. Okay. In my heart of hearts, I don't think it is, but you think it is. So you know what? Let's give it a go. Or it might be that if it is, it's high BMI, it's having a conversation really early and saying, okay, so is this something that's important to you? No, I don't want to address my weight. Okay, that's okay. But we may need to address it at some point in the future. Okay, cool. Moving on. I could try and keep the judgment out of it and address it, because it's not an easy thing to address. Like, how do you address someone's weight? That's a decades-long thing that's occurred, and you're just dealing with a thing that's occurred within the last 3-6 months. You know, you're trying to unravel and unwind a lot. So, but I do think you have to respect where the person's at, and sometimes it doesn't work because that person just doesn't gel with you, you know, like any relationship. But yeah, absolutely. I think it's especially for heel pain, because you've got so many options, or you've got a lot of options that are marginally effective. So you really have to work with what the feedback is that you're getting and where you're at. Like I said, the patient was like, I just want to do strength exercises. Okay, well, we'll do it. We'll see how far we get, but let's give it a go. And while we're giving it a go, can we just try this and see what happens? I don't care if you hate it. If you hate it, check it out. That's fine. But just humor me for 24 hours and give it a crack. And let's just, if I'm half winning, that's great. And we can always deal with the effects of that later, but let's get half a win. Yeah. Okay. Oh yeah. Well, you know, and then they come back in and they go, well, actually that was kind of helpful. Great win. All right. So let's just hold on to that for 3 months and work through what we're doing through here, which is your approach. And we might get the win together.
It does take a long time to get better, doesn't it? Do you find, you know, people can be dealing with it, especially if it's been going on for a long time? I mean, the persistent pain research would say, generally speaking, the longer something goes on, potentially the longer it's going to hang around. I mean, do you see people get better quicker, or potentially have a better outcome when they're focusing more on the function and what they can do versus the pain?
Yeah, absolutely. Yeah. And I think that's where the exercises is really helpful. So I go, okay, so if we have the conversation around, all right, this is really painful, this is really bad, blah, blah, blah. Okay, well, let's start with, wriggling your toes and just making sure that's not painful. Okay, cool. That's not painful. Great. Okay, let's do some seated calf rise, because again, that should be non-aggravating, really, but it'll get you stronger. So you might be like, oh, I'm feeling really good and strong. I'm getting the benefits that come, endorphin rush that comes out of doing stuff. Oh, okay, cool. We won't get on the walking yet. Let's just get you on the bike and see how you feel doing that. Yeah, I feel really great. Okay, cool. So now you've done all these things that are exercise based. It's probably treating the person. It's like I said before, if I put someone in with a dietitian on a bike for 3 months, I might get the same outcome as giving them a focused strength program. But yeah, I think that if that's where movement's really helpful. So you can go, okay, well, let's get some movement in there so you don't have the kinesiophobia around that. Right now you're walking 10,000 steps. Okay, well, if 10,000 steps is aggravating, can we find a way to get that down to 5,000 steps and see if we're still aggravating? Oh, no, we're not aggravating at 5,000. Okay, cool. So now let's apply the tendon model to it. All right, let's do 5,000 plus this and see if we can get that to 6, and so on and so forth.
And
interruptions.
So you were, like, I guess if people are concerned about, what type of exercises or what they could potentially offer to someone, I mean, and we'll put this down in the show notes, they can pretty easily just go check out your recent paper, which is like a whole list of strengthening exercises and really just movement exercises. Can you speak much to that? Like, was there anything that kind of came into the paper that was surprising, or the sets and the reps? I mean, it's very hard, which I'm sure you're going to say, it's very hard to be specific when you're recommending any kind of treatment to anyone, but you guys recommended sets and reps and exercises as well. Anything that you thought that was, odd or expected, or just any kind of comment on that at all?
I think so. It's all I've done is collate 40 experts, well, down to 18 in the end, experts and their opinion on what they collectively agreed would be the best way to approach strengthening exercise for heel pain. I think for me, what I found really surprising is that there's between a 20-something-year-old athlete and an 80-year-old woman, there's not a lot of difference in the two programs. And for me, I'm like, that's not how I would have done it. But that's me, right? And it's not my opinion. It's the collective experts that they've done it that way. One of the criticisms that keeps on coming through is that in the paper, it says, an 8 rep max, but we've given people a range of 6 to 10. The reason it was put together like that is because you can't just say, well, I want people to do 6 to 10 and not give some form of load. You've got to give a load. And to give people, if we were to sit there and put down 10 kilos, that 10 kilo load is not relevant to everybody. 10 kilos might be heaps for me and nothing for you, Cal. So it had to be either a percentage of rep max or the equivalent, which is number of repetition max.
Which is similar in other research as well.
Correct. So I appreciate that criticism, and I don't dispute that, because if it's an 8 rep max, well, you'd only be able to do 8 reps. But the point is that you're working somewhere within that sort of range level. The 3 big exercises that came out of it is really the short foot exercise, variations on a heel raise, and digital flexion. And I think in many ways, if that's your start point or that's where you're going, it makes those 3 make sense in the context of plantar heel pain. I think if you're going to sit down and you're going, okay, heel pain walks in, I need to give them some rehab. What am I going to do? We'll work within that. My only addition would be load it appropriately for the person. So if you've got a 70-year-old rolling in and you're doing digital flexion against a band, it might not be worth doing that with the 25-year-old athlete. So if you're going to do some digital flexion, make sure it's just appropriate, loaded appropriately. And you might not have the equipment or the facilities to be able to do that. That's okay too, right? So find another way to load them appropriately for that person. I think it's the only addition I would make that's based in that paper. But the three exercises were short foot, heel rise, and digital flexion. And I think that makes a lot of sense when you look at everything that surrounds it.
And what were you advising around pain provocation during and after the exercises?
Nothing, because that's beyond the scope of the study.
Okay.
What would I advise about pain provocation? I think
So that wasn't included as an outcome.
no. So we didn't really. The purpose of the study was really to turn around and say, okay, so if we're going to do a because if you look at, there's about 5 or 6 protocols out there for heel pain, and they're all really different. Like if you look at all of them, so you've got, say, things like the Rathleff protocol, and then you've got other things which include squats, and some which have hip stuff, and there's a lot of real variance, and that's true anyway of exercise literature. There's heaps of variance. So for me to then turn around and go, oh well, I'm going to put out an exercise program that I think works for heel pain, I wanted to go, well, I'm not going to just do my version. I want to try and see what happens if I ask all these people, I put them all in a room together and say, what would we do as a collective? Put everyone's group's names, everyone in together and get everyone. And there's some impressive names in that.
It was a mix of like academics, clinicians, and who was the third one?
And educators. We had educators, but they often, the people who I targeted as educators called themselves clinicians or academics in the end. So, but we tried to get as diverse group as possible. So that then they would say, well, if I'm going to prescribe a strengthening exercise, these are the exercises I would give, and this is the context I would give them, and these are the muscles I would target. And then they went through and they said, okay, yeah, I would give, they gave us all that. Then I went, okay, based on everything you've told us, here's an exercise program for a young person, a middle-aged person, an old person. You have to agree or disagree to every single variable that's on that list. So that was a pretty tedious process when that first came out for the poor people. But then they're based on that. If they disagreed with it, they could then say, well, return fire and say, I disagree with that exercise. I think you should do this one instead. Or I disagree with that set rep range. You should do this instead. I disagree with that frequency. I suppose that was the other thing that was surprising, is the frequency of daily or every second, like a daily frequency. Technically, that's a lot. But clearly they just want to get a lot of load and a lot of volume in these people.
Yeah. It speaks to like the habituation stuff where, just doing a very low level of load more frequently can potentially help. Like if you stretch morning, stretch afternoon, stretch all day, is that going to be better than just doing it once a day? I guess it depends on what you're trying to target. Like I typically, with people with heel pain, just give them very small doses, but as frequently as possible initially, just for them to do something. And I guess that kind of speaks to that a little bit compared to like a runner getting back to whatever, or someone that wants to be active. Like if they're hopping and jumping, doing heavy calf raises, it's like 3 times a week max. Make sure you have a rest day, that kind of thing.
Yeah, I think that's why they got to that outcome. I don't know, I'm speculating, but I would say that's why they got to that outcome. Is they're going, it's pretty low loads. You can do it every day.
Yeah. So what did you do? Just like lock them in the room, here's some boxing gloves, just agree or disagree on frequency, just go to the death.
During the middle of COVID. Yes. Spit on each other at the same time. No, it's a survey. So I rolled the survey out. So I went around the world, and then they'd sort of spit the survey back, and then go back, formulate the data, spit the survey back out. They check it and come back out. Fortunately, went over 3 rounds. They can go more, sometimes Delphis, but managed to sort of get it down over the 3 rounds. And yeah, like I said, all the experts involved, I'm really grateful to their time and their support. Actually, the amount of emails that came back saying, "Oh, thank God someone's doing it like this." So it was really nice.
Yeah, that's awesome. It's a great paper for people listening to go and check out.
Yeah, it's just nice. It's just nice to be able to sort of say, okay, well, if this is what the majority would do, so now let's test it. Now let's actually test it. Is it going to be effective or not? Because it might come out that it's not effective, in which case you're like, okay, so the experts think this is what's effective. Maybe it's not. Maybe it is.
Yeah, it's good. You're being very modest. But, a lot of people say, let's say we talk about giving someone rehab or exercise. They're always the big complaint is, no one ever says what to do or how many. No one's ever specific. Well, it's like, well, if you read the paper, it's getting pretty specific. So there's no excuses not to be recommending that now. One thing I want to talk about in that paper was it mentions the concept of like tailor neutral position and toe posture. What did obviously went through it with the fine-tooth comb, but no, I'm only kidding. But what do you kind of make of that and think of that? And when you're giving someone rehab, how specific are you? And feel free not to answer. How specific are you with like saying foot position and kind of neutral and what it needs to be like for people?
Yeah, it depends on the person. So those 2 things got they were mentioned as things to be thinking about, which I find really funny. If we just go onto a social media rant for a second, I find it really funny because you'll watch some of the barefoot zealots and they turn around and they go, don't have stick orthosis in there because they're just trying to straighten your whole foot and everything, and that's really
Brace
bad.
it.
It needs to be free, and yet I'm going to stick a flamingo toe between your toes because they need to be straight, but your rear foot can be as floppy as you want. It's kind of like, hang on a second, guys. Like, where is this? Are we going with free and I'm a tree, or are we going with I'm locking everyone up, or is the truth somewhere in the middle? And so for me, the truth's probably somewhere in the middle. And so I think with this, the toe position tailor stuff, I think based on, if you look at a lot of the biomechanics stuff, for me, it doesn't, I just know the person's in front of me is the person's in front of me. And it might be relevant that they perhaps need a little bit more offloading or a bit more prescriptive. I'm not generally like that as a clinician. I'm generally quite, okay, well, that's what we're dealing with. All I have to do is take pressure off the structure that's hurting.
Yeah.
And if I'm doing that with some strengthening exercise, or if I'm doing that with a foot orthotic, or if I'm doing that with a needle, it doesn't really matter as long as I've assessed out what the risks and the benefits are for that person. So, it might be that the strengthening exercise is the thing that gets them and gets the pressure and the stress out of that structure. But the alignment, so the toe alignment or the tailor alignment, is probably less valuable for me, depending on the person that's in front of me. For some people, it's really important. For other people, it's not really. I think I remember when before I was a podiatrist, I owned a gym which had 7 squash courts. And I remember one of the squash coaches, we were talking about technique in squash. And I tried really hard to beat this guy, but this guy was an incredible squash player. So I would just walk off dripping and he would look amazing. But he would often say, as long as the ball's landing in the back corner, it doesn't really matter how it got there. And I think it's James Kavarakis is the guy's name. He won't be listening. But if
he definitely listens. I know him. No, I'm kidding.
Definitely listens. He's a lawyer. He definitely listens.
He wants to learn about heel pain. Heel pain affects everyone. This is the podcast for the mass public.
But I still remember that conversation. And I think that's kind of true in the management here. As long as we're landing the ball in the back corner for that patient, you know what? Perhaps some of the details on that technique don't matter, but some do, because if you're going to hit it the wrong way, it's not going to go where you need it to go. So, yeah, I really like that. That still sings to me when I'm training people.
What do you find? You've definitely mentioned it before with, I guess, your education points around what people probably need to hear with plantar heel pain. It may be a longer journey and we're focusing a lot on pain, a lot on function, perhaps being aware of pain, but not focusing on it too much. But what do you see as your key education points that you think people should be discussing or talking about with their patients, and perhaps you do as well with yours?
Yeah, I mean, you mentioned that it's all about the journey and holding people's hand through it. And I think we need to take responsibility for clinicians as much as the patient does. So, when we talk about the pain's all your responsibility, well, it's also ours as a clinician. So part of the education for me is explain to people, okay, it is a journey. We have good days, we have bad days. It's a bit like the stock market. As long as we make it to the end, we're going to have ups and downs. I often talk about load. So, we've got a jug of water we're trying to fit inside a cup. If we pour it in really, really fast and it all just overflows, we've wasted our cup's usage until we can start to consume some of that water. So we need to manage that load so we don't just consume all the water at once and expect that we're going to put up with it. So load management is another big one that I think is a big conversation around heel pain. But also taking some of the fear out as well. You know what? If we can do this much, that's a win. And then if we can increase how much we do without increasing pain, or we can decrease pain within the amount that we're doing, that's also a big win. So trying to sort of reframe the perspective on it a little bit. But also part of the education is to come back to us as a clinician from the patient, because the patient will come in and they'll tell you what their expectations are. And that's an education for you as a clinician as well. So then you go, oh, okay, so that's what your expectations are. Can I meet those expectations? Because it might be that I can't. And the earlier I can recognize that, the better, because then you're not the patient I can help. And similarly, if you understand where they're trying to get to, then you can reframe some of what you're trying to do to meet that as well.
Yeah, I agree. Definitely the expectation. I mean, for a condition that can typically be quite chronic, it's common for people to come back and say, yeah, it's better, but I've still got pain. It's still sore. It's like, yeah, well, we know it's a journey. It can be 3 months, 6 months, 9 months. Timeframes are varied, but what you can do now and what you can do in the future is something that we can work towards.
Yeah, correct. And you don't really want to let them, if you're making progress, you don't want to let them go too early either. You want to just hold on to them and just go, okay, well, let's get through that next thing. Then once we're through that, let's double check. How did we go? Did we survive it? Yeah, actually we did. We did really, really well. Ace, let's high five. Let's celebrate that win. Okay, cool. Is there another win coming up? No, you know what? That was my Everest. Awesome. Well, then we've done our job. But that would be the best case. And in the worst case, there's some other little hiccups that come along the way, and it's just trying to work around that.
You mentioned the use of shockwave therapy for plantar heel pain. What do you see the main role being in its effect, and do you see it to be effective 50% of the time, 70% of the time, or can you pick which patients it might be more helpful with versus not?
Just to premise this, Kelly has had shockwave on her Achilles. She's not a big shockwave fan, although it did help. It definitely helped. Your Achilles was stronger. You were springier. You were looking younger. Everything was just, skin was better. It was crazy after you had that, but she doesn't like it. Every time she got any pain, I'm like, we got a shockwave this thing.
Your skin looked so much better.
It did. She was happier. Things were good. It was good. It was great. It was a great
The dog
day.
behaved better.
Yeah.
Should have seen it. It was amazing. The sun was shining more. Look, I do like shockwave. And the reason I like it is because really, aside from pain, short term, very short term, the side effects are pretty small and minimal. Now, it doesn't mean you roll it out for everybody. It doesn't mean it's going to work for everybody. It's like any of those treatment modalities. Like, none of them are great, but I don't mind it because it's low risk. So, and if we go back to that paper I was talking about, I've got to remember who the primary author is, but that paper, which has actually got an outline on gold standard management, it's in there as part of the gold standard management. So it has some effect. But am I going to do it on everybody? No. Like, if I'm winning with some plantar fascial stretching, there's no real value or need for me to start belting someone and making their skin better. But if we're not getting any success and I've run out of other options, I'm probably going to think about it as something to try. If someone rolls in with a bag full of foot orthoses, 3 Coles bags, you kind of go, well,
all skived.
You might modify it, and if you're still getting no success, well, you might stick some felt padding. You're still getting no success. You've stretched it, no success. You're giving them strict exercises, and you've managed all their load. And you're not getting much success. Well, maybe you would. Maybe it's better to do that than to stick a needle in them.
Do you think that there's plenty of shockwave research. It seems to be the last paper I read, some neo revascularizations, more formation of smaller new blood vessels, and potentially some change to the free nerve endings. Do you think it's just a nervous system stimulus and change that they have it for so long, for a short period of time, it's bloody sore and painful? Because people have immediate analgesic effect, and some people say it lasts for days and they come back and it's better. It's like, there's no way the tissues have changed in that long, in that short period of time, to a degree of like how long exercise would take, but their nervous system, something has obviously changed because their pain is a lot better.
100%. It might be psychosocial. Like, it might be, I'm belting you, and the people that come in and they've had a massage and they've gone, yeah, that guy's really good because the elbows just go in, and that just makes me feel heaps better. If that's the mechanism that works, take the tic tac. But yeah, I don't know enough about shockwave to know what it does and how it does it. I'm quite open to say I don't really know how it works, but if it works for you, that's great.
Yeah,
if it doesn't work,
like a book, and Kelly and I read it every night before we go to bed.
Oh, do you? Maybe that's what's fixing your skin. But
I'm looking so bright this morning.
It's amazing, the glow. I'm even getting blowback here. But I don't know enough about it. If it's not worked 1 or 2 times, I've given up pretty quickly. But yeah, I don't know why it works. I don't know how it works, but if it does work, sure.
Because it seems to be like more evidence pointing towards it being effective for plantar heel pain opposed to, well, maybe it just hasn't been studied in other areas so much, but it certainly seems to be more studied or more like recommended in the heel. And I was wondering if it had anything to do with maybe like how sensitive the fascia is, or something to do with perhaps that structure being different to other areas like the Achilles or shins or something like that.
Well, podiatrists just love toys.
They do. That's the thing.
We're just good with it. Don't be up on us about skills. You would never be able to hold a shockwave against someone's heel.
I did your knee.
Yeah, and you didn't do it right.
You got sad.
It took 4 years. 4 years to learn to hold a nozzle against someone and their foot down while they're screaming.
Yeah, I don't know. I don't know why. I wonder whether it's just because of proximity to the surface. It seems to be the stuff I've read, the stuff that's close to the proximity, like the Achilles, stuff that's close to proximity to the surface. And that's the foot as well, right? The foot, a lot of stuff's close to the proximity. So I wonder whether that's more it rather than anything else.
Yeah. Especially with the shins as well. They're quite close.
Yeah.
Down the border. Yeah. Mate, thank you so much for coming on. Really appreciate the time. I didn't think we were going to get through everything, but we definitely did. It was great.
Thanks, mate. Yeah, appreciate it. It's good to catch up.
So what's on the cards? What's in the future for the plantar heel pain research? Are you going to find the fix, the bulletproof, the treatment, the cure?
Out comes a silver bullet. No, so I've just finished putting together a draft of a narrative review, which actually summarizes all the foot and ankle exercises that have come out as a whole. Thumbs up. I'm not even doing that.
How are you getting that when you were just talking to the side?
I want to get the balloons back. Anyway, so I'm just finished doing that. So that's going to go through a few drafts before that comes out, but that'll probably be one of the next ones. The one that I am excited about coming out, there's an EMG enforced paper where we measure the torque about the MTPJs and the muscles that are active. And we've got 10 muscles, which again is a huge number of muscles. So I'm pretty excited about that paper. I got the data a few weeks ago, so I've now just got to sort of find a nice way to present that data. So that'll probably come out in a couple of months as well. And then the final paper that we're in the process of doing data collection on at the moment is an MRI study, which is measuring foot muscles on an MRI and comparing those who've got heel pain compared to those without, and seeing if there's a difference in those two populations. There's a few other papers sort of coming out in a similar vein where they're looking at the muscle quality in those two populations as well. So there's a few papers coming out with a similar sort of MRI data set, which will be interesting, I think. But certainly from me specifically, and from the amazing support from Hilton Menz and Carl Landorf, Glenn Whitaker, Matt Cotchett, and Luke Kelly. The paper around the narrative review and the EMG study and the MRI study are the next ones to look out for, and should all come out early next year, or I'll probably be divorced.
Hey, you may be divorced, but you'll have your heel pain research, and that's the most.
And I'll have a shockwave machine, and my skin will look amazing.
Yeah, all you need is a hotel room, some heel pain research, and a shockwave machine. That makes life together. And good skin, very good skin.
Good skin.
That's great, mate. Thank you for coming on. Can you give us any insight? Is there anything interesting you're finding or seeing in some of the data with any of the talk or the MPJs or any of the other studies that you're doing?
Sneak peek.
The sneak peek. So I've dropped a couple of them through this conversation, so we're going to have to rewind now. But I think you'll find that what we've tried to do for the EMG studies, I've tried to actually map it. So you can actually see force versus muscle activation, and you can then map effectively a treatment protocol based on that.
That's cool. Yep.
So then what you end up happening is you could go for, let's assume you've got a pre-surge patient who can't tolerate much load. You can then see the activity, the things they're going to use lots of muscle activity, low amount of load. So you can start to give those much earlier versus the things that are really high in load. And then targeting, and it's broken down per muscle. So, for example, flexor hallucis longus for abductor hallucis and so on. But it's fairly similar across all those different muscles, which goes back to sort of show that they all work together. So even you're trying to isolate these specific muscles, it's near on impossible because they will all work together. So the pattern's much the same, but hopefully we'll be able to map out, and that's part of the data stuff we're trying to work through at the moment. So it's a really nice, pretty picture, but you can map it and go, all right, if I've got a patient and we can sort of do this much, then we can probably start our rehab at this point and move from forward from there.
Dan, that's going to be one nice looking graph. I'm picturing the one for like the plantar flexors, if you're loading someone with the Achilles or with the shin, and it's like a step progression. Like that would be awesome. That's really cool.
Yeah, it'll be cool. I'm looking forward to it.
And for people to find you, they can go to your Instagram, Agile Foot, and then if they want to come into you, what's your address? No, kidding. They can just come knock on the door and ask you heel pain questions, can't they?
Yeah, correct. Just come and knock. Clinically, I work at Physio Sports in Brighton, Melbourne, which is the Penn Highway, Melbourne. And then Twitter and Instagram is at the Agile Foot. I have bursts of activity where I'm not head down in a paper. I'm like, oh, actually, this is really interesting. I'll pump a whole bunch of stuff out, and then I go a little bit quiet, and then a burst of activity again. So you won't get overloaded, but you won't get
underloaded, just bored. Like the plantar fascia, just what you need.
Just exactly.
Nice to finish it. That was good. Awesome, mate. Thanks so much for coming on.
My pleasure, mate. Thank you. Thank you for your time, both of you. Good fun.